Lynparza is a poly-ADP ribose polymerase PARP inhibitor indicated for the maintenance treatment of adult patients with deleterious or suspected deleterious germline or somatic BRCA mutated, GBRCAm or SBRCAm, advanced epithelial ovarian fallopian tube or primary peritoneal cancer, who are in complete or partial response to first-line platinum-based chemotherapy. Select patients for therapy based on an FDA-approved companion diagnostic for Lynparza. Serious and potentially fatal adverse events included myelodysplastic syndrome, acute myeloid leukemia. Monitor patients for hematological toxicity at baseline and monthly thereafter. Discontinue if MDS-AML is confirmed. Pneumonitis. Interrupt treatment if pneumonitis is suspected. Discontinue if confirmed. Venous thromboembolic events, including severe or fatal pulmonary embolism. Monitor patients for signs and symptoms of venous thrombosis and PE and treat as medically appropriate. Advise patients of the potential risk of embryo-fetal toxicity and to use effective contraception. Please see important safety information later in this video.
Hello, my name is Dr. Sharon Lewin. I'm the Director of Gynecologic Oncology at Holy Name Medical Center in Teaneck, New Jersey. I'm also an Assistant Clinical Professor in the Icahn School of Medicine at Mount Sinai Hospital in New York, New York. In this video, I am going to discuss the SOLO-1 trial, including the primary analysis and the subsequent 5-year follow-up analysis. SOLO-1 was a phase 3 trial of women with somatic or germline BRCA mutated advanced ovarian, primary peritoneal, and/or fallopian tube cancer in complete or partial response to first-line platinum-based chemotherapy. Patients were enrolled regardless of surgical outcome. Patients were randomized to receive 300 milligram Lynparza tablets twice daily or placebo for up to 2 years or until disease progression or unacceptable toxicity. Here we see the results of the primary analysis for SOLO-1. The median progression-free survival, or PFS, was not reached in the Lynparza arm, but was 1.2 years or 13.8 months in the placebo arm, with a median of 41 months of follow-up in both arms. Patients should be selected for this indication using an FDA-approved companion diagnostic. A subsequent post-hoc analysis of PFS in SOLO-1 with 5 years of follow-up was conducted. In that analysis, the median PFS for Lynparza was approximately 4.7 years or 56 months and about 1.2 years or 13.8 months for placebo with a hazard ratio of 0.33. The analyses at 1 to 5 years are descriptive. The SOLO-1 study was not designed to assess statistical significance between treatment groups at these time points. These data are based upon a 5-year post-hoc follow-up analysis, which was not controlled for type 1 error. Shown here are the adverse reactions, or ARs, that are reported in at least 10% of women on Lynparza versus placebo. The most common ARs were nausea, fatigue, and abdominal pain. Most of these were grade 1 or grade 2. Shown here are the most common laboratory abnormalities occurring in at least 25% of women on Lynparza versus placebo. The most common grade 3 or 4 laboratory abnormalities were decreases in hemoglobin, lymphocytes, absolute neutrophil count, and leukocytes. Follow-up for myelodysplastic syndrome or acute myeloid leukemia continued until death due to any cause. 3 patients or 1% in the Lynparza arm and no patients in the placebo arm experienced these ARs in the primary analysis. The safety profile of Lynparza at the 5-year follow-up remained consistent with the primary data cutoff. No additional cases of myelodysplastic syndrome or acute myeloid leukemia were reported. The incidence remained less than 1.5%. Dose modification was used in the SOLO-1 trial to help manage ARs. As you can see in this table, approximately 3 in 4 women in the Lynparza arm did not require a dose reduction, and approximately 9 in 10 women remained on Lynparza without AR-related discontinuation. In conclusion, in the SOLO-1 primary analysis, the median PFS was not reached in the Lynparza arm and was approximately 1.2 years or 13.8 months in the placebo arm at 41 months follow-up. In the subsequent post-hoc follow-up analysis, the median PFS was approximately 4.7 years or 56 months with Lynparza and approximately 1.2 years or 13.8 months with placebo. Testing for BRCA mutations in patients with advanced ovarian cancer can help identify the approximately 25% of patients who may be eligible for Lynparza monotherapy. Thus, it is important to perform BRCA testing with an FDA-approved companion diagnostic at the earliest opportunity to help inform treatment decisions. Next, we will review the important safety information for Lynparza.
Important safety information. Contraindications. There are no contraindications for Lynparza. Warnings and precautions. Myelodysplastic syndrome, acute myeloid leukemia, MDS-AML, occurred in approximately 1.5% of patients exposed to Lynparza monotherapy, and the majority of events had a fatal outcome. The median duration of therapy in patients who developed MDS-AML was 2 years, range less than 6 months to greater than 10 years. All of these patients had previous chemotherapy with platinum agents and/or other DNA-damaging agents, including radiotherapy. Do not start Lynparza until patients have recovered from hematological toxicity caused by previous chemotherapy, less than or equal to grade 1. Monitor complete blood count for cytopenia at baseline and monthly thereafter for clinically significant changes during treatment. For prolonged hematological toxicities, interrupt Lynparza and monitor blood count weekly until recovery. If the levels have not recovered to grade 1 or less after 4 weeks, refer the patient to a hematologist for further investigations, including bone marrow analysis and blood sample for cytogenetics. Discontinue Lynparza if MDS-AML is confirmed. Pneumonitis occurred in 0.8% of patients exposed to Lynparza monotherapy, and some cases were fatal. If patients present with new or worsening respiratory symptoms, such as dyspnea, cough, and fever, or a radiological abnormality occurs, interrupt Lynparza treatment and initiate prompt investigation. Discontinue Lynparza if pneumonitis is confirmed and treat patient appropriately. Venous thromboembolic events, VTE, including severe or fatal pulmonary embolism, PE, occurred in patients treated with Lynparza. Monitor patients for signs and symptoms of venous thrombosis and pulmonary embolism and treat as medically appropriate, which may include long-term anticoagulation as clinically indicated. Embryo-fetal toxicity. Based on its mechanism of action and findings in animals, Lynparza can cause fetal harm. A pregnancy test is recommended for females of reproductive potential prior to initiating treatment. Females. Advise females of reproductive potential of the potential risk to a fetus and to use effective contraception during treatment and for 6 months following the last dose. Adverse reactions. First-line maintenance BRCAm, advanced ovarian cancer. Most common adverse reactions, grades 1 through 4, in greater than or equal to 10% of patients who received Lynparza in the first-line maintenance setting for SOLO-1 were nausea 77%, fatigue 67%, abdominal pain 45%, vomiting 40%, anemia 38%, diarrhea 37%, constipation 28%, upper respiratory tract infection, influenza, nasopharyngitis, bronchitis 28%, dysgeusia 26%, decreased appetite 20%, dizziness 20%, neutropenia 17%, dyspepsia 17%, dyspnea 15%, leukopenia 13%, urinary tract infection 13%, thrombocytopenia 11%, and stomatitis 11%. Most common laboratory abnormalities, grades 1 through 4, in greater than or equal to 25% of patients who received Lynparza in the first-line maintenance setting for SOLO-1 were decrease in hemoglobin 87%, increase in mean corpuscular volume 87%, decrease in leukocytes 70%, decrease in lymphocytes 67%, decrease in absolute neutrophil count 51%, decrease in platelets 35%, and increase in serum creatinine 34%. Drug interactions. Anti-cancer agents. Clinical studies of Lynparza with other myelosuppressive anti-cancer agents, including DNA-damaging agents, indicate a potentiation and prolongation of myelosuppressive toxicity. CYP3A inhibitors. Avoid co-administration of strong or moderate CYP3A inhibitors when using Lynparza. If a strong or moderate CYP3A inhibitor must be co-administered, reduce the dose of Lynparza. Advise patients to avoid grapefruit, grapefruit juice, Seville oranges, and Seville orange juice during Lynparza treatment. CYP3A inducers. Avoid co-administration of strong or moderate CYP3A inducers when using Lynparza. Use in specific populations. Lactation. No data are available regarding the presence of olaparib in human milk, its effects on the breastfed infant, or on milk production. Because of the potential for serious adverse reactions in the breastfed infant, advise a lactating woman not to breastfeed during treatment with Lynparza and for 1 month after receiving the final dose. Pediatric use. The safety and efficacy of Lynparza have not been established in pediatric patients. Hepatic impairment. No adjustment to the starting dose is required in patients with mild or moderate hepatic impairment. Child-Pugh classification A and B. There are no data in patients with severe hepatic impairment. Child-Pugh classification C. Renal impairment. No dosage modification is recommended in patients with mild renal impairment. CLCR 51 to 80 milliliters per minute, estimated by Cockcroft-Gault. In patients with moderate renal impairment, CLCR 31 to 50 milliliters per minute, reduce the dose of Lynparza to 200 milligrams twice daily. There are no data in patients with severe renal impairment or end-stage renal disease, CLCR less than or equal to 30 milliliters per minute. Please see complete prescribing information, including medication guide, at the URL shown on the screen. You may report side effects related to AstraZeneca products at the URL shown on the screen or by calling 1-800-236-9933.
Thank you for your time. I hope you found the information presented to be useful for your clinical practice.